Good morning, everyone, and I echo Henry Hoffman's comments. I hope you all are staying safe this very unfortunate time in our history. And given the fact that so many of you are recovering from your strokes, it's all the more important that we exercise extreme care for our health and our safety. The information you see on the screen right now kind of tells you who I am. I've been around for quite a bit of time. I'm proud to be a member of the Scientific Advisory Board for Saebo. And most importantly, I've been working with patients who've had strokes for well over 40 years now, and probably treated or evaluated several thousand patients. So I've had a vast array of experiences. Henry was kind enough to suggest that I'm a visionary. I don't know about that, but I do want to share with you some thoughts about where we are today, where I think we are going in the future, how that might benefit anyone who's had a stroke, or caregivers or partners who are helping us in our recovery process. So this is what I'd like to cover in the next 30 or 35 minutes. I want to talk to you very briefly about what is working in stroke recovery, and actually, what do we mean by the word working? Talk to you a little about the timelines for stroke recovery and actually what we mean by recovery. Several people are concerned about this idea of spasticity of muscles. We can talk a little bit about what is it and how can it be improved upon. Then I want to move towards the concept of home-based treatment, the role of the therapist, the care partner, and you, because I think we are beginning to experience, and we will experience further, the reality of more and more of our therapy being done in a home environment. And ironically, it's a shame and also a blessing that this pandemic has put us in a position where the opportunity to do some home therapy and to interact with our therapists is improved upon because of this pandemic. And the reality that once this pandemic ends, and I hope it will be soon, the idea of home therapy and communications with clinicians is not going to go away. It's going to continue, and we'll talk about that a little bit, which brings us to this concept of telerehabilitation. What is it? What does it mean? And what is our respective roles in telerehabilitation? And to make it very clear to you that telerehab, this communication electronically, is an option for what we do in the clinic. It's not an alternative. I don't want anyone thinking that because we have this opportunity to work with you from afar to your home, it is not intended to be a substitution for clinical treatment and clinical therapy and one-on-one therapy, but to complement what is already being done. And you can imagine at this point in time, any ability to communicate with therapists and get help when you're wanting to be safe and can't necessarily go to a clinic safely is a welcomed addition and possibility. And then last, the future. What might rehab look like in a few years? And what are some of those changes? And how might they impact you or your family members? So what is working in stroke recovery? So working is a relative term. When we look at ourselves, and if we've had a stroke, we say, well, I'm doing better, but I might not be as good as I can be. What should be happening for me to get better? What works and what doesn't work? And to answer that question it's a difficult one. And there is no fine answer, but let me give you a couple of examples. In all of my years, I have never, ever met a patient who's had a stroke who feels at the end of their rehabilitation that they're the same as they were before their rehab. They could be a little bit better, they could be very, very much better, but I can't do a very specific task as well as I could before my stroke. We always are self-critical. We want things to be perfect the way they were before, and that very rarely happens. So I'm going to try to have you do an exercise at home, a very simple one. For those of us who are trying to have rehabilitation for our upper extremity, the question arises, what's available for me and what is my potential? So if I can ask you, if you're near a table or a chair, if you can put your arm from the elbow down onto the table or the arm of the chair so that the undersurface, the palm surface of your forearm is resting on the table or chair. Now I'm going to ask you, without moving your arm or your forearm at all, can you begin to raise your wrist and fingers up as though you're trying to wave goodbye to someone? That is, try to raise your palm up from the chair or the table without moving your forearm and starting to open your fingers. That's important because what we've learned over the years is that to get the best rehabilitation possible, if someone has that movement capability within 10 to 12 weeks following their stroke, then the potential for using some procedures can be defined by your ability to do that. Henry made reference to forced use or constraint therapy. We know from many years of research and study with patients that if you have those movement capabilities, raising your wrist up, starting to open your fingers voluntarily, and you can do that a few times slowly and directly within 1 minute, not many times fast, but a few times slowly, then the idea of constraint therapy, where you can begin to open your hand and use your upper extremity under the guidance of an occupational and physical therapist, while your better arm is immobilized, making so that you can't use it, then the potential for gaining more and more function is there. If you don't have that possibility within 10 to 12 weeks, then other forms of treatment might be appropriate. And certainly the magnificent work that's been done at Saebo to help keep your hand open, and then you can close it in the presence of situations where you can't voluntarily open your hand, has been incredibly helpful and very creative in assisting patients to make better use of their weaker, we call hemiplegic upper extremity. What else is on the horizon? And you may have heard about. We are always trying to find ways in which we can rewire your brain or make those pathways which are there but haven't been used sufficiently better. We call this concept, and something you may have heard of before, neuroplasticity, the ability for the brain cells and how they communicate with one another to reconnect or to work more efficiently. You know, many years ago, we used to believe that when a person had a stroke and some of the brain cells died, nothing could be done. There was no potential opportunity for some kind of functional rehabilitation. But we now know that indeed, there are many, many, many amongst the millions of brain cells that we have that can be rewired to work successfully with these various interventions, something that we didn't even think was possible just 1 or 2 decades ago. So one of the procedures which is being used now is called transcranial magnetic cortical stimulation, TMS. That's a big phrase. What that means is placing a stimulating probe on your head, which passes actually a magnetic pulse through your skull and is converted to electrical energy that makes your nerve cells work. And we can determine whether we can actually get some of those muscles that at the end of your hand or at the end of your foot to respond to that kind of stimulation. If we know that can happen, that too offers us potential for further use of this magnetic stimulation in conjunction with therapy to make those nerve cells that connect to the end of your hand, or your arm, or the end of your leg to work more effectively. So many therapists now are beginning to combine this transcranial magnetic stimulation, TMS, means through your skull with a magnetic pulse to make nerve cells work. It's not painful at all. What one feels is like a little tap on your head. That's the extent of any discomfort. And that is now being combined with ongoing therapy at the same time, so that while you're being stimulated, you're also trying to activate the muscles that are being targeted by the stimulation to make your hand or your forearm work more effectively. What is being studied right now, the best way to do that, because like so many other things, one size does not fit all. Based upon where you've had your stroke in your brain and what cells might still be active, helps us to decide where that stimulation should occur and what we should be instructing you to do voluntarily with that stimulation. So I wanted you to know that this is an intervention, an approach, which is now being developed further. I want to make it also clear, this is not what we call deep brain stimulation. This is not a surgical procedure in which someone puts electrodes in your brain. This is done superficially by passing a magnetic pulse through your skull above the portion of your brain, which is responsible for the motions that are activated when we do that stimulation. So improvement is relative. Back to the idea of what's working and how much will I improve. And what I say to my patients, and I want you to think about, is answer the question, what can you do today that you could not do before today? And those occur in small steps. For an example, if you have some movement in your hand and you'd like to pick up a cup, the idea is not necessarily, can I pick up the cup today because I couldn't do it yesterday? These changes with the therapy begin in small steps. So now, can you bring your hand to a cup when you might not have been able to do that the day before or the treatment before? Can you begin to open your hand just a little bit around that cup? Can you grasp that cup? Can you now lift that cup and start to bring it to your mouth? These are all small steps leading to an important function that occur in sequence. They don't always all occur right away at the same time. So my point is that improvement can be measured in small phases, all leading to the big picture, which is the true function. And it can be something like picking up a cup, to being able to straighten out your elbow, to get your arm into the sleeve of a shirt where you couldn't do that before without assistance. It's all relative. So please understand that improvement is not meant to be all or nothing. There are steps that lead to the totality that is function. And each thing that you could do today that you couldn't do yesterday is all part of that improvement process. So let's talk about the idea of time. And when I've had my stroke at this point in time, what's the recovery look like? So this funny looking picture here, as you can see on the straight line, that's time measured in months. The horizontal, the line, vertical line going up, can be any measure of function one chooses. And the higher the curve, the more function you get. This is more function, this is more time. And as you can see, if we center on these points where the slope begins to improve, those individuals who have had a mild stroke, which would mean the ability to move your arm up, straighten out your elbow, begin to open your hand, so your arm maybe feels more weak than truly hemiplegic, that rate of improvement is very fast over a relatively short period of time. Those folks who've had a moderate stroke, which means you can do some of those activities, straighten out your elbow a little bit, you can begin to raise your hand up, you can begin to open your fingers. That rate of improvement is a little bit slower and is not as great as if you had had a mild stroke. And then folks who've had a severe stroke, That rate of improvement can occur a little bit later, and it's not as great as of improvement as even a moderate stroke. So there are gradations of how much we can improve right now with most of the therapies that are available to us that are based upon whether we categorize the kind of stroke we had as mild, moderate, or severe. Now, when we add to that the entire concept of recovery, recovery is defined as the amount by which someone has improved in any outcome measure over a unit of time. So this is an ongoing, continuous process where we hope that the therapies that we're trying to discover now will change these slopes so they get higher and last for a long period of time. So our goal then in recovery is to make your function as good as we can, recognizing that recovery is a continuous process over the course of many months. Now, if one doesn't move much beyond this point here, but can do activities, we refer to those activities as compensation. What does that mean? That means that you're not using your arm as nicely as you would. In order to succeed in using your arm, your elbow, your hand, you have to do substitution movements, strain your body, do additional help with the other hand so that a task can be completed. That's compensation. The other extreme, if you're fully recovered, is restitution. Restitution means that your arm, your hand, your functions look almost the same as they did before you had your stroke, or look just like the opposite hand and arm. That's the other extreme. Compensation at the low end, restitution at the high end. The entire process is referred to as recovery. So we all vary in the amount by which we recover. There are two extremes, and I want you to understand that recovery is a continuous, ongoing process. There are questions about spasticity. What is it, and how can it best be treated? So spasticity is basically an imbalance between muscle groups that have opposite functions. For example, you can raise your wrist up, or you can lower your wrist down. Call that extension and flexion of the wrist. Often, when someone's had a stroke, the imbalance occurs in such a way as the muscles that bend your elbow become more powerful and continuously active relative to the muscles that straighten your elbow. The same is true for bending your wrist versus straightening your wrist, or bending your fingers versus opening your fingers. And in fact, I'm sure that some of you listening to this webinar have experienced or seen patients who have their arm by their side, their elbow bent, their wrist bent, and their fingers closed. That's because all the muscles that perform those functions are overpowering the muscles that have the opposite function. And the reason that this occurs is because the nature of where the brain injury occurred creates a change in the outflow of the brain cells going to these muscles in such a way that those that bend the elbow or the fingers or the wrist become disinhibited. They're on overdrive. And the muscles that have the opposite function, straightening the elbow, raising the wrist or fingers, are weak and can't override the power of the descending nerve cells that make the hand and fingers close. Now, when we try to take those muscles that are making your wrist or fingers bend and try to open them in the opposite direction, we can feel a resistance to that. That resistance, if it's driven by this imbalance of nerve cells coming from the brain, leads to a lack of fluid motion. So if you can imagine the therapist trying to open your wrist, and they feel some struggle to do that, they eventually do it, but they feel resistance as they try to do it. That's because as those muscles that want to bend are now being stretched, they don't like that. And they want to close again reflexly because the sensitivity of input to those muscles that bend is so strong that changing their length unexpectedly causes them to recoil or shorten. That process is referred to as spasticity. Does it last forever? Not necessarily, because what happens sometimes, if you feel the spasticity, it may subside, but what is left is an imbalance, not caused by any further by this imbalance of nerve cells coming down, but the muscle length and the tendons actually have shortened. And now they are in a shortened position because they have been in overdrive for so long. So you may no longer have spasticity, but you may have muscle shortening or tendon shortening, which can be a consequence of prolonged spasticity. And sometimes we have a difficult time distinguishing between spasticity and muscle or joint tightness caused by shortening of muscles. So what can be done for spasticity? I suspect some of you listening to this webinar have had botulism toxin injections, sometimes referred to as Botox, directly into select locations of muscles. What that toxin does is it relaxes the nerve impulses coming from the nerves to those muscles. So the connection between those nerve cells and the muscles is no longer there, which means that the muscles won't contract like they were before. The drive to them is inhibited chemically. And those of you who've had Botox may recognize that once those muscles that bend your elbow, your wrist, or your fingers get weak by after a few weeks of the Botox, you might be able to now open your hand or raise your wrist up. The Botox, unfortunately, is not long lasting. It may just last for a few months. It might require additional injections. The success of the Botox is really based upon the accuracy and the selection of the right muscles by the physician who is doing the Botox injections. What about medications? There are medications such as the baclofen, which are designed to relax muscles. These medications, for the most part, basically are sedatives. And while they may relax your muscles so that the therapist can do more with them, they also have the side effect, because they are sedatives, of making you groggy, not as alert. The point being here is that the medications that we use to relax muscles, aside from Botox, are not specific just to the muscles. They have a systemic effect as well of making you overall relaxed, tired, perhaps a little fatigued, with less energy. Let's move on to this concept of home-based treatment, the role of the therapist and the care partner and you. Well, you can't be going to the clinic every day forever. So the question then is, how do we do the best we can with working from home? And most of the time, the therapist can give you a prescription of exercises he or she wants you to do, and we hope that you do them. We have not always been monitoring them accurately. We have tools now that allow us to do that, but we also have the capability of monitoring what you do, and I'm going to explain that in a moment. And so we can't be going to the clinic forever. So a therapist can come to your home, and that perhaps some of you have had home health therapy after your stroke, or you can be evaluated from afar. And that can be done by the therapist. What is happening now is this concept of telerehabilitation. So what is telerehabilitation? Conceptually, it means the ability to monitor what you do from another location through the use of a monitor, let's say a computer screen, and direct verbal communication with the therapist. The therapist is actually watching you in your environment as you're doing exercises and makes use of what he or she can see to help you with those activities that are designed to make your arm or your leg better. So this is a treatment at home, and as I said before, it is an option, not an alternative. This doesn't mean you never see the therapist again. The therapist doesn't touch you. It means that during those periods of time when you don't go to the clinic, the possibility of the therapist communicating with you directly at home is there. The therapist can help you then modify your responses. And what's happening now is the development of tools such as exoskeletons that help you. These are like braces that are put on your arm or your leg that help you move that arm or leg in certain ways, but can be connected to visual presentations that are related to how much you are moving a joint in your arm or your leg. And you can be trained to change your responses by seeing what's on the screen that's related to the movement. Most of these visual pictures are actual games than which a bar on a screen may raise more as you activate your muscles more and increase your motion. What's added to this is the concept of creating challenges, because the amount of difficulty in those games can be changed by the therapist. And in today's contemporary use of gaming and instruments, it is now possible for a therapist in their clinic to operate or change some of the gaming interfaces in your home as you're working with a patient from afar through using Wi-Fi as a communication tool. And so the games can be created, the challenges can be increased, and soon we're going to be in an environment where a patient in one home can actually compete against a patient in another home on the same game, so that you and the patient elsewhere try to reinforce one another's activities and efforts by interfacing in these games, and these in their own way are challenges. So recently, I did not notice, I came across a small camera called made by, it's called WISE, W-Y-Z-E. It's maybe 4 or 5 inches tall and 5 or 6 inches wide. The camera can move 360 degrees around the space or up and down 180 degrees, and can actually follow you while you're making a movement with your arm, for example. And that camera can be controlled by the therapist. And he or she can see much more of your environment than they could see before by just looking at a computer monitor. So this is one of the technologies that is now being introduced to help us see more clearly how you are performing in the home environment. Now, all of that's very good, but there are concerns, and I've had this discussion with several of my patients and others, and I hope you can appreciate what I'm about to say. Does this mean that if you have a camera and you're watching me in my home from where you are or from my computer screen, that you can watch me anytime you want? That's not fair, and I don't like that. I see that as kind of an invasion of my privacy. Well, that's a very good point, but what now exists so that one does not have to worry about these things, the most simplest approach is simply to put a cloth or towel over the camera when you're not using it, so no one can see you. But the sophisticated notion of these interfaces now allow us to turn off the camera until you choose to activate it. And you hopefully activate it when you have an appointment with with a therapist for a telerehab session, or when you say you're going to activate it. And the therapist only knows that you've activated and what you're doing when you turn it on, and they can see that. In other words, you have control of the camera to avoid the possibility of feeling as though someone is intruding upon your privacy. So now the future. What might rehabilitation look like? You know, beside from the pandemic, we are faced with a healthcare crisis where we no longer are going to be in a position to pay for all the services that we would all like, whether it's in rehab or other aspects of healthcare, post-surgical, behavioral, etc. So not all treatment is going to be in the clinic. which invites the possibility of home-based therapies. These therapies this is in a way good if you stop to think about this, because if you're going to work through telerehab with a therapist, this now avoids you having to go to a clinic and deal with transportation issues and other factors that may make it harder for you to get there. If you live some distance from the therapists who are treating you, the ability to do this from a long distance is also beneficial. And perhaps equally as important, you can schedule the telerehab service therapy anytime it's mutually agreeable. So if you have a care partner who's going to participate with you and he or she is not available till the evening because of work or whatever reasons, a telerehab treatment can be scheduled at that point in time. So there's lots of advantages here. Again, this is not meant to replace the therapist's hands-on. It's meant to complement what is being done. So the beauty here is that with the devices that are now being developed, everything from electronic sensors to Fitbits and other devices that can monitor your arm movements or your steps, there's a possibility of continuously monitoring some form of movement even when the therapist is not with you. Now you might say, well, that means again that they're spying on me and they know all my motions? Well, in a way it is, but on the other hand, if we as therapists can demonstrate, record this information and have you transmit it to us or pick it up from your Fitbit or sensor on your arm or leg, it gives us information about just how busy and active you are. And we can convey that information to third-party payers to justify further treatment for you. So it's a win-win situation for all of us. I've already made reference to group-based activities and exercises by way of communication. I think we're going to be seeing more and more of use of your counterparts in other homes or locations working with you the same time you are, so that you can engage in an exercise for your arm or your leg and see how each of you are doing. And aside from the therapist, you can begin to reinforce and give positive assistance and encouragement to one another. So those are things that lie in the future, which I think are pretty exciting. And the recognition, once again, that these advances in technology are not designed to replace the therapist. They're designed to complement. And the reality is that in all probability, as we look to the next decade, the resources available to allow us to see a therapist every day or 3 times a week for X number of weeks may not be there. And we need to be prepared to use other resources and technologies to be of assistance to us. So at this point, let me stop. And Henry, turn it back for a moment. And there might be at least 1 or 2 questions that have been generated.
Yeah, that was a really great overview. Dr. Wolf, thanks so much. I think you touched on a few things, and I'm going to make a few comments and ask a question also. But while I'm doing that, guys, just as a reminder, there's a questions tab on your mobile device. You'll see a question mark or it says questions. Feel free to type your question and we'll address it as time permits. Also, if you haven't answered the poll question, there's a poll right there. Are you currently seeing an occupational or physical therapist? You can select one of the following right there. Go ahead and type that in. It's for the attendees here, and then we'll address that as we discuss, but you should be seeing that as well on your screen. I'll just give it a couple more seconds, and then we will go ahead and close.
Henry, while that's going on, I neglected to say something that's very important. So if I may. You know, one of the consequences that can occur as a result of having had a stroke is this feeling of feeling isolated and sometimes actually being clinically depressed. The intention here is to try to get past that and assist in some way. And I can't emphasize enough, because this has already come up in some of the patients with whom I've been fortunate enough to engage in telerehabilitation. This feeling of being isolated, when you can be in your own home environment and know that you can communicate directly via computer monitor with someone who's trying to help you in some capacity, I think does a lot to eliminate, reduce the sense of being alone or isolated, because you have the security of your home environment on the one hand, and the knowledge that you're actually working with someone who's trying to help you on the other. And that's been very helpful for folks. The other issue I refer to is this notion of depression. That is something that, of course, any patient can discuss with a therapist in person or on the phone, or on telerehab. What we have found also is this notion of gaming, where you feel challenged by trying to see the relationship between how your limb movement can be improved by virtue of you trying to win at or improve a game. The game has been inspiring to many people. The extent to which they feel better, happier, more engaged, we've not measured yet. But there are some people who are now studying this relationship between the inclusion of games and challenges to patients and how it might improve their overall behavior and disposition in life.
Excellent. Yep. Well said. Well said. So thanks for completing the poll there. It looks like less than half of you are attending occupational or physical therapy, so that's a good reference point. And keep asking the questions. We'll get to those in a second. Just a few other points. You mentioned spasticity, Steve, and we talked about, and by the way, treating spasticity is very difficult. And I know the folks on this call definitely can appreciate the complexities that go with a tight hand. And I know there's treatments out there. The ones that are the most well-known is going to be a combination of the Botox you mentioned, or a lot of people do electrical stimulation to reduce spasticity, or splinting. So for individuals on the call, if you're not doing anything for your spastic hand or affected limb, definitely reach out to Saebo and do a free consultation so we can talk about that more and what the options exist. Steve, you had a graph that kind of talked about the first 12 to 13 weeks. If you don't have certain recovery, it gets a little bit more challenging for you. Do you know, I know we've had many conversations about our patients who are chronic, meaning greater than a year, let's say, who still show really good progress. And some of the folks on this call may be those stories where they're 2, 3, 4 years out post-stroke and they're still making really good progress. Right. So I know it's not black and white, but do you recall what the statistics are regarding what percentage of patients get most of their affected side back in the first 13 weeks, 12 weeks? Is it tiny?
Right. It's remarkably much lower than we would like. It's in the order of, based upon who you want to believe, 15 to 20%. Okay. Look pretty darn good within the first 12 weeks. But there's another 40 to 50% who would fall within that moderate range on that. Can I see if I can go back here? Who fall within that moderate range, and of course, then we have 30 to 40% of individuals who are very, very severe. And what we're trying to do here is to prevent undue pain, enhanced function, and the ability to use that limb in an assistive capacity. The challenges that we have, and I can get into this later if you want about some of the newer interventions, is we struggle, those of us that put on a research hat for a second rather than a clinical hat. You see this curve here. What we're trying to do, particularly in the moderate and severe folks, is figure out interventions that can improve the slope so that we see greater change in a shorter period of time. And after we answer some questions, I can tell you about one or two of those areas, which are very exciting and being studied right now.
So pun intended, we definitely do not want to flatten the curve under this condition. We want to keep it going, right?
Indeed.
Okay. Yes. All right. Let's get to some questions in no particular order here. We do have a bunch. Hopefully we can get through most. what would you recommend? Would you recommend using a massage gun? I don't know if you're familiar with massage gun to help relieve tightness from spasticity. Are you familiar with massage gun?
I am.
Steve?
I'm not. I don't. I've heard it,
It's
but I
like a
don't know
vibration
the
tool.
mode.
So
Yeah.
I've used these vibration tools too.
Mm-hmm.
And I believe there's some research on vibration and spasticity, isn't there?
Right, there is. So so this is the tricky part. Remember I mentioned that sometimes when you stretch these muscles or try to change them, they recoil and get tighter. I think the massage gun concept is good if the massage is either over the muscles that are weak, but if it's over the muscles that are hyperactive, those are the ones like bend your elbow or bend your wrist or bend your fingers, the frequency of the vibration can affect the response of those underlying muscles. And the problem is that we all don't respond the same way to the same frequency. So if it's 60 to 80 cycles per second is causing that vibration, that might wind up being relaxing to underlying muscles in one person, but might actually facilitate, increase their tone in another person. So one of the cautions that needs to occur with any form of vibration is what is the relationship between the frequency of the vibration and the response of the patient to that vibration. And we cannot assume that all patients respond the same way to a given frequency.
Yeah, well said. And another one on spasticity is, what is the best exercise for spasticity in upper arm muscle? And I know that could be a whole 45-minute presentation, but from your perspective, what are the top things that come to mind regarding best way to manage, whether it's an exercise, or I know you discussed Botox, I know we talked about e-stim and splinting just now. That's our spasticity kit, if you will. We do electrical stimulation while stretching to the weakened agonists while stretching. Anything else come to mind as far as exercises? I know strengthening has shown it's not contraindicated. Strengthening actually is helpful in spasticity management. Anything come to mind for you?
No, I mean, the question is one of practicality. What can be done practically in your personal space to try to reduce spasticity? And the best answer is stretching, and prolonged stretch, and doing this on a regular basis. And then in the absence of the actual stretching itself, is to try to engage in some relaxation exercise, that is mental relaxation, to see if you can then passively and gently move stretch the muscles that you've been stretching previously slowly, and see if you can move that joint a little bit further before one begins to encounter the resistance to the movement, which is a manifestation of the spasticity. So if we can do prolonged stretch and then see if we can take our hand or the stretching device away and then passively do this very gently, can we actually begin to move the muscles that we want to stretch a little bit further before we feel that resistance? Trying to stay relaxed is an important aspect of that. In fact, we can do functional electrical stimulation to the antagonism, and there's some very sophisticated things that can be done. So just imagine that your muscles that bend your wrist are spastic. And of course, if you start to straighten out and raise up your wrist, you feel this resistance and the urge to want to bring the wrist back down. That is a manifestation of spasticity. But you know, if we could stimulate the antagonist muscles, functionally electrically stimulate the wrist extensors, and if we could monitor the muscles that bend the wrist, we do that with EMG, or monitoring muscle activity, so that the patient can see, as you're stimulating to raise the wrist up, what's happening to the muscles that are being stretched on the undersurface of your wrist, and look at the muscle activity by sensors put over the muscle. Can you, seeing that muscle activity or a visual representation of it as a line, a figure that moves. There are many ways in which this can be done now. Can you actually relax that line so that as you're being stimulated, your wrist is going up, the muscles are being stretched on the undersurface that want to fight back and close. Can you look at the muscle activity on a screen and try to keep that as relaxed as possible while the stimulation is going on? So what I'm saying here is that the FES is there, the functional electrical stimulation to raise your wrist up or raise your fingers up is being activated, but the muscles that are being stretched and want to close again are actually being monitored so that you can see them with something called EMG feedback.
Right.
And you volitionally try to keep them relaxed by lowering the signal of those hyperactive muscles on stretch while you're doing the FES.
Yeah, that's a good way to do it. And we love the stretching of the spastic muscles while stimulating the opposite muscle group.
Yeah, yeah.
All right, so we have a lot of questions, so we'll try to get through these. Let's do 30-second, 1-minute responses for some of these, and let's see if we can get through these. Dr. Wolf, what is TMS? No, excuse me, TMS is experimental. Where is it available? Is it experimental, and where is it available?
Yes, very good. Yes, it is experimental for everything, for what we do in rehab. The only reimbursable TMS at this moment in time is for depression. You can stimulate certain parts of the brain repetitively and actually reduce signs and symptoms of depression. That's a whole other topic. TMS is totally experimental, and it's not being reimbursed right now, but the slew of publications that are showing the benefit for TMS as a treatment tool is increasing, and it's only a matter of time before it becomes potentially reimbursable. What it is very good for as a precursor, a preparation for treatment, is to do the stimulation to see whether you can get a response. It's an evaluative tool. When you stimulate above your brain, your motor cortex, and you look at the response in muscles with surface electrodes, EMG, in a distal location, it tells us if you can see those responses at the right timing, that indeed the nerve cells going from your brain to that area is intact. And that tells us we have the potential to build upon the activation of those nerve cells by you and not by the TMS.
Yeah. Specifically with that, again, the next question, they ask, the question is, the magnetic pulsing you mentioned, can it be used in patients with aneurysm clips? And how long out from the event can it be used?
Oh, good. I mean, that's the whole thing about TMS use is another topic. It is contraindicated for any implant whatsoever, whether it's a cardiac pacemaker or in your brain.
Okay. Next one, your recovery timeline showed months. How is the recovery different 10 years after stroke?
Well, once again, it kind of depends on where you are at that point in time and if one could trace the history of your stroke. I'm going to take the worst case situation. If you were, I guess, classified as having had a severe stroke, and that was the situation a year or 2 year post-stroke, and you were to look at that person 5 or 10 years later, it's highly unlikely that the amount of improvement is going to change. On the other hand, and you made reference to this earlier, Henry, there are patients who we think have plateaued, which you see kind of here in this figure, here and here, and they continue to improve once you start seeing them again. That can be accounted for 2 ways, and they're both very encouraging. One is perhaps the nature of the therapy that they had during the acute or subacute phase of their stroke simply did not challenge the patient enough, and patients had greater potential to improve more than the therapists were able to elicit from them. The other is that your nervous system is continuing to readjust, and those neuroplastic elements I was talking about were latent and they were sitting there and needed to be revisited. The nature of what we do several days, weeks, or months later can be such that we now have figured out a way of engaging those nerve cells that hadn't been done before. When I was growing up, just to divert just 1 second, I remember doctors saying, boy, that therapist has great hands. That patient would do anything for that therapist. Well, I think what they mean is that therapists, those great therapists, are folks who figured out ways of tapping into the nervous system that hadn't been done before by creatively challenging patients and recognizing motions that might not have been there before and building upon them through the specific therapies. That's what I think they meant.
Yeah, that's a good way to describe it. Good, that's interesting. Another one, we'll just do a couple more here. What do you consider severe for a stroke? In other words, they're trying to quantify or classify what severe is versus moderate, perhaps?
Yes. So, I mean, to keep it very simple, I think you've all, hopefully everyone listening on this call has heard of the term synergy, a flexion or extension synergy, a gross exaggeration of motions across joints in one direction in the upper extremity. Typically it's flexion and adduction of the shoulder, flexion, bending of the elbow, wrist, and fingers. The inability to isolate any one of those elements from the synergy, that is, you can't voluntarily move your arm away from your side, or start to straighten out your elbow, or start to raise your wrist or your fingers. The inability to do that would all fall within the domain of a severe stroke. Now, moderate, on the other hand, is you begin to move out of those synergies in one or more joints. Mild is that you can do maybe all of those joints, but not very well. That's why I asked that original test about trying to put your forearm down, raise your wrist and fingers up so you're waving goodbye. We can learn a lot from what your potential is and how one can be classified, at least for an upper extremity, based upon the ability to do that. And I can tell you a little secret. Every time I meet a new patient in person, I always initiate the hello, well, I can't do that today, by deliberately shaking hands with their hemiplegic or hemiplegic upper extremity, whether it's left or right, because that tells me a lot right away. And the patient's not even aware or conscious of what I'm trying to do. If I see movement in which the wrist is starting to come up or the fingers starting to move open, even though they can't totally do it in shaking my hand, I know that patient has great potential. I've already made that decision before we've even started treatment. So that's why I asked about that one particular task that people can try to do on their own.
Okay, finally, we'll end with, we're 2 minutes over, but we'll end with this one. And then for the folks on the call, you have my email. Feel free to email me additional questions and we can address those offline. Foot drop. We didn't really talk about foot drop. We talked about arm and hand recovery. I mean, obviously, Saebo has solutions for the leg. We do electrical stimulation. We have the foot drop device called the Saebo Step also. When it comes to treatment, not much really is different when you're thinking of foot drop and spasticity compared to the hand and spasticity. Is there anything that folks should do differently when working on foot drop besides having the appropriate orthotic?
Well, the appropriate orthotic is outstanding. Once again, this notion of FES to the extensors and everters of the ankle, and trying to activate those during the swing phase of gait is very helpful. We're developing some really kind of sophisticated stuff now. This is a whole discussion on its own, in which we're actually providing feedback of the ground reaction force. That is the amount of force you push off with, and show that as a game to a patient with each step. And we find out there's a correlation between their ability to improve in their push off, and that reverts to their swing phase of their gait. So the totality of their gait, at least at the ankle on down, improves with we call ground reaction force, or force feedback during actual gait in patients. But that's a whole nother topic.
Yeah, that's interesting that you mentioned that.
There are new technologies that are developing that are designed to be very helpful for improving gait in stroke.
As a side note, the audience will appreciate hearing about this as well, but for you specifically, Steve, do you remember our Saebo Mount Track Infinity, which had the reciprocal EMG triggered stimulation?
Yes, yes.
So what we've done, it's more for the advanced clinician. It's something that a patient would not take home because it's a little bit more complicated of a device. The hope down the road is to make a simpler home version. It's very affordable. That's just not in the cards right now, especially with the whole pandemic and addressing priorities. But we do have technology that I think the laboratory would like, and feel free to use, where it's an EMG triggered stimulation device, which is for the audience. EMG triggered means biofeedback triggered, which means you elicit a movement, a contraction of a muscle or relaxation of a muscle, the sensors detect it, and then they reward you with stimulation. So we would put EMG on the plantar flexors. Those are your calf muscles that are spastic, that push off, as Dr. Wolf just mentioned. Well, surprisingly, or not surprisingly, most stroke survivors have very weak calf muscles, very weak plantar flexors. They hardly can activate them. Yet most of the time is spent on stimulating the toe lifters, or also known as the dorsiflexors, and spending very little time on the plantar flexors, or that large calf muscle. So reciprocal EMG triggered stimulation through our device puts the sensors on the calf muscle, which is very weak, and monitors the activity as they try to push off. And knowing that their calf muscles are weak, the clinician sets the threshold of when the stimulation will kick in at the right time once you achieve a certain threshold of push off, if you will, or activation. So just a reminder, Dr. Wolf, if you do have foot drop specialists addressing this need, feel free to tap into the reciprocal EMG triggered stimulation technology we have through that Saebo Mount Track Infinity. It's really nice. It's very underutilized because it does require a higher level of problem solving by a clinician, which sometimes is difficult to find. And that's a whole nother 45-minute presentation.
Absolutely.
Okay. Well, listen, we couldn't get to all the questions. Feel free to email me. Thank you so much for a very thoughtful, meaningful presentation. We will definitely continue to do more of these for the audience from different clinicians ranging from aphasia, speech, vision, psychology, and of course, lower extremity, upper extremity. And Dr. Wolf, you've been great.
Thank you so much. And I hope that if those of you listening in could learn anything from this that will be helpful, then it is time well spent.
Absolutely. Well, we're going to conclude there. And thanks again, Dr. Wolf, for your time. And we look forward to helping people in the future.
Good luck to everyone. Stay well.
Thanks. Take care.
Bye-bye.